Welcome back, clinical problem solvers.
Woo!
You're a bit delayed there, my friend.
No, remember, I'm never interrupting you again. Look how clean shaven this is.
So it's still working well for you?
Oh, it's amazing. It's one of the best gifts I've ever received. I've never because not because it's amazing, but also when you're at -5 plus 30 feels great, because I had this like horrible $20 shaver that like just was horrible. So now, oh man, worst world class shaving is my life.
Dude, I
But
can't
nothing
wait
compared to yours.
to. The truth is, like, I think it's going to even be more impressive when we travel and give talk because that
Yeah,
that shaver is a toothbrush too.
I can't. Yeah, I don't brush my teeth with it now, but I'm
Yeah.
saving that. I'm saving that. What's new with you, Prof. Rez?
Oh gosh, I just finished a run, but
Yeah.
this weekend has been incredible because there were two derbies this
Oh
weekend in the Premier
yeah,
League. And
yeah.
actually, I woke up at 4 a.m. yesterday
No way.
to watch
You
Manchester
watched it?
United versus Manchester City. I mean, for me, I just enjoy great football, but I really wanted Manchester United to win because I
Yeah,
always favor the underdog.
yeah,
And Man City has been dominating the Premier League for the last couple of years. So
yeah,
just to see them be down 1-0, but
yeah.
if we're being, I actually was a referee when I was 14 years old.
What? Really?
Rashford was definitely offside
Yeah,
because he
100%.
was involved in the play where the
Yeah,
other defenders paused. Like they were
yeah,
influenced by Rashford's action.
yeah,
So it shouldn't have been a goal, but I think that
yeah,
was the spark that led to the second goal that Rashford scored.
yeah.
And I looked up, how he points at his head after he
Yeah,
scores.
why does he do that?
So I looked this up and I mean, I'm just interpreting it based on the first Google link I saw. But basically, he's saying I have mental strength. Like I'm not emotional, like I'm mentally
Yeah,
strong.
I
I'm
like that a lot.
focused.
That's awesome.
He points
Yeah,
at his head.
that's awesome. You should do that after getting today's diagnosis, by the way.
I
You ready? I've been
I
hyping this
am
one for a
ready.
long time.
And I ran 5 miles beforehand. So even if I don't get it, I'm still feeling great for the
That's
next hour.
amazing, yo. All right. So disclosure. I saw this patient at segment X of his journey, not at the beginning, but for the purposes of storytelling, I will pretend like I was there for all of it. Okay? Instead of telling you a boring story of like he came to me in this state, I'm gonna pretend like I was there. 54-year-old man who is you can tell is soft spoken, gentle, kind, but worried. He's worried because he, out of the blue, started to get more and more swelling in his left lower extremity. And initially he chalked it off, but the swelling became so bad that he could really not walk very well. It was just very uncomfortable for him to put his shoes on, so on and so forth. And so he comes into the emergency room where his vitals are normal. He has no other complaints, no systemic symptoms. And on exam, the only thing that you find is that he has 2+ pitting edema to the mid shin with no associated skin changes. It's pretty tense. And I'll stop there.
And Robbie, was it symmetric or was left greater than right
Just
or
left.
just left leg? Okay.
Just the left leg. The right is pristine.
This is really, really helpful because right away we have a clinical problem that we're solving. We don't have the tempo for this problem yet.
Two
But
weeks.
oh, 2 weeks you said. So we did have the tempo. Maybe I wasn't paying attention.
No, 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 I forgot to say it, but it's
Oh,
important because there's a lot coming.
okay. 2 weeks. Got it. Perfect. So whenever you're categorizing the tempo, you want to categorize it as hyperacute, acute, subacute, or chronic. Right now, we have a problem that's in that subacute, acute to subacute phase. And the problem is left lower extremity swelling. In a middle-aged individual, we don't have the background data yet, being the past medical history. And there's something that's important to note about anatomy, and that's the following. Any cause of volume overload or edema should slightly cause more swelling in the left extremity than the right. And the reason for this is that the left iliac vein goes under the right iliac artery. So just Google image this and you'll see. So there's always mild compression there. That being said, if it's noticeable to the eye, you shouldn't assume that you're dealing with the cause of bilateral lower extremity edema, like a problem with the heart, the liver, the kidney, or a medication that can cause bilateral lower extremity edema or venous stasis. So here, we've already made a lot of progress because we're dealing with unilateral, asymmetric, lower extremity edema to the mid-shins. Of course, we're going to find out if there's any other symptoms to suggest pathology elsewhere. But when you're approaching this specific problem, the number one diagnosis you should consider is a clot, is a DVT. So in all comers with asymmetric swelling, you're already thinking, am I going to get an ultrasound of this lower extremity? Another very common cause of asymmetric lower extremity edema is cellulitis. Now, the patient may have findings of systemic inflammatory response syndrome with like a fever, tachycardia, leukocytosis, though you could have mild cellulitis that causes swelling and some redness. The 2 weeks duration without it getting better makes me question that possibility. I'm going to do one last thing because I think the easiest way to know the causes, so that was just my reflex was, is it a clot? Is it an infection? But if you really wanted to take an analytical approach to asymmetric lower extremity edema, just take an anatomical approach, take an arrow and go through the leg. We already talked about the skin and soft tissue. We already talked about the subcutaneous space. Then you have the muscle, you have the fascia, and you even have the bone. So where I am, Robbie, right now, if this person's coming to me in clinic or to the ED, I'm getting a lower extremity ultrasound. And if it doesn't appear red and there is no fever, I don't even think I would get labs, to be honest. I would just start with an ultrasound, but interested in hearing more of the story.
Absolutely superb. I love both the like base rate approach and then the analogical reasoning in case that base rate doesn't pan out. And as predicted, it doesn't. His DVT ultrasound is negative. And interestingly enough, here are his labs. His CBC is normal. His renal panel is normal. His LFTs are normal. And so he is discharged with the diagnosis of venous stasis. And I'll stop there for you to reflect on that.
You know, first of all, this is not unusual to have edema, get the ultrasound, and it be negative. So you got to be very cautious before continuing. What do I mean by being cautious? You have to make sure that the ultrasound had adequate quality to the study. Just because the study is reported as negative doesn't mean it truly is negative. It all depends on what your pretest probability is. So in a patient like this, I would quickly, determine what is his risk for a clot, and that would determine whether I completely trust that ultrasound or if I want to repeat the ultrasound. Another way to do that is just like talk to radiology or look at the report. Did they actually visualize the various points of the lower extremity before ruling out clot? This hypothesis of venous stasis is the most common cause of lower extremity edema in patients over the age of 50. And it results because the valves of the veins are not functioning properly. As we age, everything worsens, including these valves. An atypical presentation of a very common disease is conceivable. So maybe the clinicians like venous stasis is most common. I ruled out the emerging cause being a clot. So maybe this is atypical presentation of venous stasis. But I'll tell you, I think already we have a red flag because it's very odd to just have venous stasis in one extremity if you think about the pathology of venous stasis. It's not, why would the valves of the venules be affected just in the left leg? And Robbie said 2+ pitting edema. So it's not just mild edema. So to have that stark contrast, it would make me question that hypothesis. And if that edema honestly is as impressive as you say, Robbie, thinking of that anatomical approach, I would actually pursue a CT scan of the abdomen, pelvis, and lower extremities of that left side to see if there's a mass compressing the venous system or the lymphatic system.
Amazing. The quality of the ultrasound was superb. And so 2 months, 3 months later, he comes back, and this time to an emergency room. The edema is so severe now. It's gone up to his mid-thigh. And he also now has pain when he bears weight. It hurts when he stands, as opposed to it was uncomfortable, the leg was too thick, so on and so forth. Examine him, and you see that the edema is very, very impressive, and that he has pretty significant edema. Basic labs, I'll tell you, and I'll stop. His CBC is normal. His renal panel is normal. His liver enzymes are normal, except an OCPHOS of 376.
All right. And Robbie, the color of the leg, totally normal?
Normal skin, yeah, but
Normal
just
skin.
really tense and tight.
Very tense and tight. Okay. I think that I'm concerned here because of the pain that the patient is experiencing. Whenever you have pain in a swollen extremity, your first question is, was there some type of trauma leading to a fracture in the extremity? But oftentimes when people have fractures, one, they present pretty quickly after the fracture as opposed to months later. Two, they give you a story of some form of trauma. So I'm framing this problem as atraumatic, severe left lower extremity edema that's progressive and now associated with pain upon weight bearing. And Robbie told us that it's quite tense. So if we remove fracture from the possibility explaining this patient's pain, what you really are worried about here is vascular insufficiency. And you're worried about vascular insufficiency based on Robbie's exam and based on the progressive nature of this problem. So how can we have vascular insufficiency in a patient? Well, there's multiple ways, but it comes down to the arteries. And actually at the capillary level, you're just not perfusing well. So why might that happen? You have some kind of arterial pathology, like someone has severe peripheral arterial disease. So when they walk, they develop claudication, or they throw off an embolus and they block the blood supply to the leg. The mind is going to experience this as pain, right? But there's no clues for peripheral arterial disease, and that just wouldn't match the illness script of the swelling that this patient's having. So now you wonder, could there be venous insufficiency? So when patients develop blood clots, one of the complications, the long term, is actually the venous pressure rises so high that the arteries are unable to supply adequate oxygen to the tissue, leading to the pain experienced by the patient. The reason I asked about the color is because when you have clots and you develop these symptoms, you can have phlegmasia cerulea dolens or alba dolens, where literally
Smokes, how do you pronounce that so well? That's amazing.
I had to practice it for every day for a year. The leg either turns blue or white, respectively. But there's two other categories we have to consider here. So one was venous insufficiency. So could there be a mass involving the left iliac vein compressing, and it's just growing and leading to all of this edema, the tenseness, the pain with standing? And by the way, when the patient stands, they're pooling more blood into the extremity. So they would, if there was vascular insufficiency of venous origin, it would actually worsen with standing, while arterial, it would improve because gravity is helping push the blood downwards. But the other two categories you have to consider, whenever you think of vascular insufficiency, you got to think about neurogenic cause of pain. That always goes in the DDX with a peripheral arterial disease, but why would a neurogenic cause this degree of swelling? So I'm eliminating that. But the other one to consider is compartment syndrome. So Robbie said this leg is extremely tense. And when you have such a tense extremity, you can easily imagine that just the fascia and the pressure that's building up there is compromising the blood supply, leading to pain. Usually when you have compartment syndrome in an extremity, it's rapid. It's an acute process. Again, this has been going on for some time, and you would imagine that that compartment will adjust and adapt given the slow nature. Now we have a chronic issue. So moving on to the lab. So just to summarize there, I think that you have to worry about venous insufficiency, less concern for arterial insufficiency. You have to worry about compartment syndrome, though the tempo is not completely consistent with that. I would send a CK in this individual. I would get a CT scan to see if there is compression of a vessel or if there's an occult fracture that we didn't pick up. Like I had a patient with diabetes who we thought had a DVT, then we thought had cellulitis, but ultimately had Charcot's arthropathy from, on fractures unbeknownst to the person who had diabetes. So let's talk about the alk phos. This is like one data point that may help us make more progress. Though reflexively, I'll say it's not helping me too much. With the alk phos, you got to determine, is it of bone origin or is it of liver origin? Right now, we have no other clues for this being of liver origin, meaning we don't have a bilirubin that's elevated, an AST that's elevated, an ALT that's elevated. Though, when you have isolated elevations in alk phos of liver origin, it usually means that you have some kind of infiltrative process that's infiltrating the liver. So in this patient, I would send a GGT because if that GGT is elevated proportionally to the alk phos, then I can say it's coming from the liver. If it's not elevated, then it suggests that it's coming from the bone. And alk phos in the bone is an enzyme of osteoblast. So the moment you get alk phos elevation could be if you have a metastatic disease process that is primarily osteoblastic, like prostate cancer, or you have a fracture and now you're trying to make up the fracture so that osteoblasts are active. And so you get an elevation in alk phos. So I think, Robbie, the GGT will help me try to frame the edema in the context of infiltration of the liver or frame the edema in the context of fracture or metastatic disease to the bone.
Absolutely superb. It's really hard when you know the answer to just like, yeah, I think I when you listen to this again, because I know you'll do the case recap. That's part of the cool part of doing those is to see how superb your discussion is and how anticipatory is of every single step. In fact, you got somewhere much faster than I was expecting, so I added a little bit of extra aliquot. Okay, so this is the penultimate aliquot, and then the next one will reveal the diagnosis. So, he gets a CT scan, and it shows multiple osteosclerotic and mixed lesions in the femur, along with a pathological fracture of the hip joint. He also has multiple lesions, similarly mixed lytic and sclerotic, in the pelvis. I was really surprised, really, really surprised. But in some ways, like you said, he's having difficulty bearing weight and he has a bony problem. So I go back and I examine him more closely, and then I feel a large amount of previously completely missed left-sided inguinal lymphadenopathy, at least 2 to 3 centimeters in size on the left and nothing on the right. I'll stop there.
Oh man, that's a bit worrisome for the patient. And I'm going to actually try something here because, Robbie, if you recall, and I think this is a good time to plug for our listeners, that it's not just these episodes that we release on the podcast. Robbie and I reflect after every case, and we create multiple figures and multiple videos linked to the figures. Because remember, I hope you're enjoying this. I hope you're laughing and it's stimulating. But the ultimate growth happens during the reflection. So we really encourage you to go to our website, click on the case link a week later, and you'll see these episodes where we reflect on the medicine. The reason I'm bringing this up is, remember your patient, Robbie, who had that lesion in the skull, and they did a biopsy and it was vanishing bone syndrome. So then we created a video on how do you approach bone lesions. And so what I'm literally going to do right now is I'm going to pull up my whiteboard schema for this. And I have no shame in doing it. And while I do that, Robbie, tell us something entertaining. Did I lose you? I can't hear you.
Oh, you can't hear me? Oh,
Now
you
I
missed
can,
it.
now I can
I
hear.
told you the most amazing thing. I can't believe you missed it. That was so sad. The really entertaining thing happening now is that my dog is snoring. And so I'm having to intermittently time the muting so that you don't hear loud snores because, Prof. Rez, I didn't tell you earlier, this poor guy ran 8 miles today. He's not meant to run 8 miles. So look at him. Look at him right here. I don't know if you can see. Look at that guy.
Oh my gosh.
He's in a coma.
That's incredible. So how long did you run for?
8.5 miles.
8.5 miles, but over what time period?
Oh man, I wish I remember. Probably on average 10-minute mile.
That's incredible. Like
We run
absolutely
faster than that.
incredible.
But then we gotta stop and pick up the ball because somebody will drop it, so on and so forth.
Incredible.
But yeah, he
Um,
likes to run.
so Robbie, what I
Yeah.
have in front of you, that enough of the chit chat. Now I have my schema up and I'm ready to talk.
I know my place in your world, man. I know it. Don't you worry.
So so basically, when you're approaching this problem of bone lesion, the radiologist is your best friend. And ultimately, there's four key questions. One is, what is the epidemiology of the patient? Are they greater than 40? And or is there a history of cancer? You ask that question because most often it's going to ultimately be a malignancy in that population with widespread, lesions of the bone. Then I think what's really helpful is when you talk to the radiologist, second thing is like, what does it look like? What are the imaging characteristics? Because the radiologist often can tell you what it's most consistent with or give you that DDX. Finally, is it symptomatic or not? And we know that this patient actually had a fracture. So this is a pathologic fracture of the bone. And then you want to look at the labs. And we already have one of the labs being the alk phos. So we anticipated this problem. So I'm going to actually tell you really what my main concern here is, Robbie, is a malignancy. Why malignancy over infection, over endocrine disorder? Well, one is like just the location, the like primarily involving the extremity, the localized lymphadenopathy. To me, that prioritizes an infectious or malignant process over something like endocrine like PTH, hyperparathyroidism. And then if you're dealing with infection versus cancer, you're like, this guy has no, signs of infection, no leukocytosis, no fever, no travel, etc. So then you're here dealing with malignancy. And then the question becomes, are you dealing with a liquid cancer or a solid cancer? The fact that it's not diffuse lymphadenopathy, it's rather localized. And given the age of the patient, I'm favoring a solid cancer, though note that lymphoma can certainly go to the bone. And what I'm trying to do here is determine if I can make any more progress on what specific cancer. I think you would just think, what are the most common malignancies? And maybe the location of that adenopathy, though you have to be cautious interpreting that because that's what you were able to detect on exam. We don't have cross-sectional imaging of all the other lymph nodes. Maybe we're dealing with diffuse and not isolated lymphadenopathy. But if you're dealing with more focal lymphadenopathy, then you worry about a GU malignancy, specifically something like prostate cancer. Prostate cancer notoriously, goes to the bone. I don't know why.
His PSA was 1,500.
Really?
I can't. I told you when somebody's discussing it so good. How do I hold back this information? Yeah.
I'm glad because I was just talking too much. But
No, are you just like that was so yeah. Well, let me tell you what happened.
please.
His PSA is 1,500, and they immediately started him on androgen deprivation therapy, and then he was transferred to a specialized academic center for complicated orthopedic surgery to repair this fragility fracture. So I'll let you reflect and do your thing. But yeah, I couldn't hold it any longer.
Quick question for you. So
Yeah.
was the edema ultimately like from the
Yeah.
fractures that led to the edema, or
I think you said it earlier. I think he had lymphedema.
Oh, he had from lymphatic obstruction. Wow.
Yeah, I think
Um,
so. Yeah,
here's
that's
my
what I think.
here's my reflection. I think that, and I would love to hear your own insight because like Robbie works in the emergency department. He sees so many patients every day. Do you feel like honestly, like if you see someone with 2+ edema on one extremity and the DVT ultrasound is negative, do you stop there or do you pursue a CT scan? I'm just trying to say I don't think of venous stasis being asymmetric like that, but maybe that's a gap in my illness script for that.
Yeah. As you can tell, I've thought so much about this case because I'm literally asking the question, how does one detect the disease before it causes this devastation to the patient? I don't know the answer to that, but I'll share this reflection. Just like you did at the beginning, you were like, wait, Robbie, tell me immediately, is it bilateral or unilateral edema? I think that distinction is so key because of the following. Bilateral lower extremity edema is initially analyzed as a systemic disease, heart, liver, kidney, meds, endocrine. And then after a decent evaluation, you conclude in many circumstances that is venous stasis. But the journey first says systemic and then arrives at local in many circumstances. Unilateral leg edema is the exact opposite, right? Unilateral edema is it a local disease, venous stasis, DVT, cellulitis, and then when you're having trouble figuring out, you usually radiate your workup to the retroperitoneal area where the lymph nodes and the venous obstruction occurs. So I think that you should, when you have when your diagnosis of venous stasis for unilateral leg edema has to be made after you think of the systemic evaluation for unilateral leg edema, no different than your diagnosis of venous stasis for bilateral leg edema. You have to first think, is there a systemic cause at play before I render this diagnosis? And so I think that I didn't see his leg. I'm just describing it based on how I was describing the notes. But what chances do we have? I think the chance that you have to diagnose this is lymph node exam. And I think that given how many, he had actually had multiple DVT scans, he had like 3 or 4, and we repeated it again, it was negative again. Given how prominent his edema was described, I think you would probably found pathological lymph nodes on that side. So what was my personal takeaway? Bilateral lower extremity edema, I go through the system, and I come back to venous stasis. Unilateral lower extremity edema, I start local, but before I render venous stasis, I have to think of lymph nodes and vascular obstruction. And if there's an IVC filter in place, if there is history of vascular surgery, if the patient has pelvic fullness, or if the patient has lymphadenopathy, I'm getting a CT scan. Yeah. Thoughts?
I That's so educational. I love that approach. And and just so the audience knows that this episode, as you're well aware, is sponsored by Glass Health. And this is a digital notebook that I use every day. And so how will I use it in this case? I already have an approach to bone lesions. So that's done. I'm just going to watch the video on rlrcpsolvers.com that we made. But I don't really have like the greatest approach to unilateral
Mhm.
edema. So I'm going to create a page on unilateral edema. There, I'm going to create a schema for it. And it's going to
Wow.
be in my Glass notebook, and I'm going to link it to this case. So I'm going to be creating it in the context of the case you presented. So I'm not
Yeah.
just reading random medicine. It's actually, driven by a case encounter. So thank you for
Yeah.
that, Robbie.
And people should trust the schemas you make, because the truth is that you essentially made the schema that I thought about and worked on for 2 days on the fly. When presented with unilateral lower extremity edema, you were literally said, "Hey, is it DVT or cellulitis?" Then I told you the DVT scan is negative, and you're like, "Wait, the pretest probability of DVT is so high that I'm gonna not trust this test fully, and I'm also worried about central venous obstruction and lymphedema." Like you said that, and then when given the labs and given the alk-phos and the exam, you're like, "I need to image this pelvis." And yeah, I think it was really cool to see that even though you had not constructed the schema, that you had used all the knowledge that you have and analogical reasoning to like construct it in real time, which was like, as a presenter, challenging, because I thought this case was gonna, like, this case stretched me a lot in real time. I had no idea what this person had until the CT scan, and I didn't think of I didn't have this like pin to branch out back upstairs to the abdomen when I haven't figured out the leg. But you seem to have that ready on speed dial today, which was really
I
cool to see.
I love that, and I really do think it's like, yeah, we like I have this approach that we created on the fly, but when we go and we read about the
Yeah.
top using art, like your knowledge just grows so much more. And I can't wait to do that. And like,
Yeah.
and for our audience, please check out these the videos that we create. Like Robbie just
Yeah.
created one on acute pharyngitis. I haven't watched it yet, but I can't wait to watch it. It will make you a better teacher. It'll give you better understanding, and it will stimulate you to even learn more. So we spend a lot of time on these videos. So please watch them.
100%. You know what they do? I think you just made me realize what they do is they make your on the fly approach codified in your mind for much longer. Like if you didn't do the reflection now, this on the fly stuff would not have been worth it. It probably would have faded in a month or two and you would have lost it and had to start from scratch. But if you what you're doing now will let it live in your long-term memory for the days of Alzheimer's dementia. Or I wish
Thank
you
you
well,
so.
Prof. Rez.
Oh, it says sign us out, my man.